Welcome to tonight's webinar on navigating the community mental health system with MHAM CEO and President Mary Ann Huff. If you are needing MCBAP or Social Work CE, a survey will be sent to you after the webinar. For everyone else, a very brief survey will be sent to you, and we hope you check in with us and let us know how we're doing and give us your feedback on content. Again, if you are wanting any kind of CE tonight, please drop your full name into the chat and we'll go ahead and get started. I'd like to introduce to you Ms. Huff, who is an LMSW and has 20 years plus of leadership experience, including 15 years of executive level staff leadership and advocacy within the behavioral health field. Prior to MHAM, Mary Ann served as the Executive Director for Allegan County Community Mental Health for 6 years and as the Director of Advocacy for the Ability Center of Greater Toledo in Ohio. Additionally, as an advocate at the Michigan Protection and Advocacy Service, Mary Ann helped individuals and families across access mental health services and uses her personal lived experience to optimistically and passionately lead, advocate, and educate to improve the lives of those who struggle with behavioral health challenges and eliminate barriers to the timely and effective treatment of severe mental illness. Welcome, Mary Ann.
Thanks, Kristen. Hi, everybody. Hope you're doing well. Of course, we have notably spring weather and winter, but it's nice to see everybody. And thank you for being here today. As Kristen indicated, I'm Mary Ann Huff. I'm the President and CEO of the Mental Health Association in Michigan, and we are going to be talking today about knowing how to access and navigate the community mental health system in our state. I'd like this to be interactive. So what I'm going to do is my presentation is going to be about 45 minutes. There's a lot of information here, but you will get a copy of the PowerPoint. And you can ask questions at the end. I'm going to leave about a half hour for questions at the end of the presentation. If there's anything that comes to mind when I'm speaking, you can put your questions in the chat. Kristen will be monitoring the chat, and I'll do my best to answer those questions. This presentation is geared toward individuals seeking services, family members, loved ones of individuals, professionals who do not work in the community mental health system, who might want to assist others, or if they have their own clients in accessing the public mental health system. And in order to put all of this into context for you, I will be talking briefly about the history of the public mental health system so that you can understand its evolution, how we started 60 years ago on Halloween of 1963, and where we're heading almost 61 years later in 2024. I do want to say it's a very complicated mental health system. If anybody here has found themselves having to navigate it either for themselves or somebody else, it's very complicated. What we're going to focus on today is not only an overview of the system, but the funding of the system, which is really important for anybody who accesses the system for services. If you're helping somebody else to advocate in the system, you have to understand the funding streams and where the money is actually coming from, because that's going to tell you what your administrative remedies, in other words, what your advocacy tools are. So without further ado, I'm going to go ahead and I'm going to get started. And again, you will have access to the PowerPoint. This is being recorded and it will be put up on our, we have a YouTube channel. So I'm going to go ahead and share my screen. And I hope that everybody can see this okay. Everybody can see this all right? Question mark? Okay, I'm going to go ahead and get started here. So want to also mention that last year, the reason you see town hall series is because Kristen and I went to some communities around the state, and we did the same presentation in different spots around the state. So we were in Traverse City back in August. We were in Grand Rapids at Hope Network in February, although there was an ice storm that day. There was actually a storm in Traverse City. We were at Clinton Township at the Macomb Community College, and then we were also at an Armenian church in Southfield. So part of our mission has been to provide information about how to access these services. Just a little bit of data for you. We're affiliated with Mental Health America, which is a national organization, and they're our parent organization. And every quarter we get data from mental health screenings that people from Michigan can take. It's actually through the Mental Health America website, but we get the data. And every year they compile the data. And in 2023, Michigan ranked 35th in the country when it comes to having a number of adolescents and children with mental health conditions and a lack of access to care. So in other words, only 15 states in the country have lower access to mental health treatment and supports than we do, and more children and adolescents with behavioral health conditions. So given all of that, and as our mission is to educate, we thought it would be helpful to continue this series into 2024. So thank you for being here today. Okay. Okay. So we're going to focus, one thing about the community mental health system in our state, I don't know how many of you are aware of this unless you are from another state, but Michigan has a very unique mental health system for two reasons. One is we're one of the few in the country that serves all of the different groups of individuals under one umbrella. In other words, we serve adults with serious mental health conditions. We serve children and adolescents with serious emotional disturbance. We serve adults and children with autism, developmental disabilities, intellectual, cognitive disabilities, physical disabilities. When I worked in Ohio, as Kristen was referencing earlier, doing advocacy, that system was split into adults and children with mental health conditions and substance use disorders, and then folks with developmental, intellectual, cognitive disabilities were served under an entirely different system. The other piece that to keep in mind is that Michigan is one of the few states in the country that has what's called a behavioral health carve-out. And what that means is that the Medicaid dollars that we get from the Centers for Medicare and Medicaid are literally set aside only for community mental health, which means that health plans can't access those dollars. So we're going to talk tonight about what is community mental health, or you might hear it referred to as public mental health in Michigan because it's funded exclusively with public dollars. Who does community mental health serve? Who's eligible for its services? What types of services does community mental health provide to those who are able to get in the door? What happens if you or your loved one or your client is denied services? So like, what are your rights if you can't get in the door? I want to also talk about terminology. So, because we have a lot of acronyms in the behavioral health world, I will refer to the publicly funded mental health system as CMH, or community mental health. The CMH system is funded primarily with Medicaid and state general fund dollars. We'll talk about that. That's important. System doesn't really deal much with private payers or private insurance companies for the services it provides. And it's also important to know that in 2014, when the state general fund dollars were significantly reduced because of Medicaid expansion, the system became primarily Medicaid funded, even though the CMH system is required by state law, and we'll talk about the Michigan Mental Health Code, to serve those who have no insurance with its state general fund dollars. Another term, something else to know, is we're going to talk about, you'll see a lot of references to a prepaid inpatient health plan, which is a federally defined Medicaid managed care organization. That's important to know. We'll talk about that. You're wanting to understand what services are available and how to get them. It's important that you know the Michigan Medicaid Provider Manual. We used to call it Chapter 3. This is updated quarterly, and there will be a section called Behavioral Health and Developmental Disabilities. That's where you're going to go to look for everything that you or your loved one or your client is eligible for. And finally, we're going to be talking partially about the Michigan Mental Health Code, which is Act 258 of 1974. That's when Michigan took all of the laws pertaining to mental health in the state and combined them into one act. It also created the county-based mental health system that we have currently. So let's talk a little bit, basically, we're going to start with the history, but I overall call this presentation How to Get into the Community Mental Health Door 101. Okay, so what exactly is the CMH system? Basically, in Michigan, it's county-based. It's a system of publicly funded mental health services and supports that are supposed to help adults, children, and youth with more significant mental health conditions, developmental, intellectual disabilities, autism, serious emotional disturbance, substance use disorder, to live as equal members of the community, and with the services and supports that make integration possible. As I referenced earlier, and so this is a little bit of the history, community mental health turned 60 years old, and the system began when John F. Kennedy signed the Community Mental Health Centers Construction Act of 1963 into law. And at that time, we had over 500,000 individuals across this country in state psychiatric hospitals. And one of the drivers behind we talk about deinstitutionalization, we tend to focus on the 70s and of course the 80s and the 90s, but really this was the beginning of deinstitutionalization. It was well known that conditions in state psychiatric hospitals, and I hate to use this term, but schools for people with developmental, intellectual, and physical disabilities, which we called intermediate care facilities for the mentally retarded. Those different hospitals, schools, whatever term you want to use, had deplorable conditions in them. And so one of the things that Kennedy wanted to do was he wanted to get people out of institutions. And of course, I think a lot of people know one of the drivers was the fact that his sister, Rosemary Kennedy, had a diagnosis of both a mental health condition and a developmental disability. So one of the factors that, really helped along the creation of community mental health, which basically it was, let's get people out of institutions and get them back into their communities. For folks with mental health conditions, with more severe forms of those, it was the invention of chlorpromazine, which we know as Thorazine, was developed by the French in 1951, approved in 52, and came to the United States in 1954. And there were a lot of side effects to chlorpromazine. That's a whole other presentation about where it came from, how it was manufactured. But basically, it was this drug that made policymakers believe that we now have some treatment, because prior to this, we had no antipsychotics. We had electroconvulsive treatment, shock therapy, as people know. We had, at this time, believe it or not, Dr. Walter Freeman was still doing prefrontal lobotomies on people. As a matter of fact, he lobotomized John F. Kennedy's own sister, Rosemary, which he did not even know about that till he became president. So it was because of this idea that we have treatment, we don't have to keep people in institutions, that one of the drivers behind the creation of a community-based system of care. Unfortunately, as you can imagine, it was an unfunded mandate. And at the time, it was like, well, we'll treat everybody. And then what's happened over the years is, and this is in Michigan too, it now serves only people who have the most significant or most severe conditions. So I'm not going to go through all this, but by the 70s, you know, that's what we were looking at, was mainly people with the more significant conditions. So for our purposes in Michigan, we have 46 community mental health service providers. They changed the name to service providers in the mental health code a few years back. They serve 83 counties. If you want to, learn more about your county's community mental health provider, here's a link for you so you can look it up. We do have multi-county community mental health services providers. For example, here on the west side of the state, we have West Michigan CMH, which is Lake Mason and Oceana County. Reason being, some of these counties were too small to have their own actual community mental health. So a lot of them joined through the Urban Cooperation Act to create these multi-county entities. One thing to know, and this is for those of you that are advocacy minded, and is that the members of a CMH board are appointed by the county commissioners. I'm not sure how many people know that, but know that there's 12 members of the board. Now, what's interesting is that if you see, it says there shall be representatives of providers of mental health services, recipients, or primary consumers of mental health. If you're not familiar with the lingo, we call persons receiving services consumers. I struggle with the term, but that's the term we've got. Agencies and occupations having a working involvement with mental health in the general public. But here's what you need to know, especially if you're a family member of a person served. It says at least 1/3 of the membership shall be primary consumers or family members. And of that 1/3, at least 1/2 of those members must be or shall be primary consumers, and all board members shall be 18 years of age or older. So putting it out there to some of you, if you're, having struggles with your local CMH, or you want to influence public policy, when there's an opening on that CMH board, you might want to consider applying for the opportunity to sit on the board. Okay. So as I said earlier, Act 258 of 1974 basically in our state gave counties the authority to set up community mental health centers. And as previously said, the idea was to get them out of institutions. In 1981, when we had the Michigan Department of Mental Health, what happened was they created what was called shared and full management contracts with community mental health. What that meant was that the state of Michigan, and at this time we had 49 community mental healths in the state. This meant that the Michigan Department of Mental Health, which a lot of you know was then named the Michigan Department of Community Health, and then not too long ago became the Michigan Department of Health and Human Services. That meant that the Michigan Department of Mental Health managed 49 contracts. They managed 49 general fund contracts, and we'll talk about the funding in a little bit, and 49 Medicaid contracts when we started getting Medicaid from CMS for mental health services. It means that the CMH then assumed full responsibility for providing mental health care in its county. The other piece was that CMHs at the time were also responsible for paying for any of their folks that were in state psychiatric hospitals. That is no longer the case because of general fund cuts. But for a long time, if a CMH had a person in the state hospital like Kalamazoo or Walter Reuther or Caro, they were responsible for that, meaning the CMH was. So if you want to understand how to get help from the system, you have to follow the money. So how is community mental health funded? Well, as stated previously, for a long time, we had general fund only. Then when we got Medicaid, it was Medicaid and general fund, because state general fund dollars, which are state tax dollars, by the way, they are used to draw down Medicaid dollars. And so, you know, at the time, again, I go back to, we had all these individual contracts. So this was pre-Medicaid managed care, which is what we have currently. I already talked about that. Nowadays, so there's another slide in here, but I'm just going to mention it now. So when I was a director back starting in 2010, before the general fund cuts and before Medicaid expansion, I would say about anywhere from 6 to 10% of the CMH's budget was state general fund. And then the remaining portion, there's some local dollars in there, but the remainder was Medicaid. Now, in 2014, when the Medicaid was severe, or the general fund was cut by 65%, that was when CMHs were not able to provide the services that they're actually obligated to provide under general fund. And many have said we're Medicaid only. I mean, I get calls from people saying, I called CMH such and such. They told me I don't have Medicaid, therefore they can't serve my loved one, which is not necessarily true. Now, what we have currently is on the Medicaid side, which I think everyone knows, Medicaid is federal money. The money is sent from the Centers for Medicare and Medicaid Services. It comes down to the state of Michigan, and then the state of Michigan through the legislature allocates a certain chunk, if you will, of Medicaid. If a lot of you know, right now we're in the middle of the budget process. The governor's budget was released on February 7th, and so now the House and the Senate will start looking at their budget priorities. But basically, right now, CMH system, I think, is about $3.5 billion between general fund and Medicaid. A Medicaid waiver, in broadly speaking, a waiver allows states to do creative things with Medicaid. So, for example, we have now what's called the 1915I waiver. 1915I refers to a section of the Social Security Act. A little history, public policy, or social welfare history. Social Security Act was amended in 1965 under the Johnson administration. And that was when the Medicaid program was added, the Medicare program was added, a lot of social welfare programs were added. So when you see 1915I or 1915C, it's really referring to a section of the Social Security Act of 1935. So HCBS stands for Home and Community-Based Services, and these waivers are all about, again, what I talked about right at the beginning. It's about keeping people out of institutions. And so the services under the I waiver, which anybody served by community mental health, if they meet what's called medical necessity, should be able to access. Those specialty supports, is really what we call them, are there so that people can live in the least restrictive setting. And our 1915 I waiver was approved in 2019 and started on October 1st of 2022. I already talked about when state general fund was cut by 65%, it really negatively affected adults with mental illness and children with serious emotional disturbance. And that's because their services are not funded in entirety, in some respects, the same way that services are for individuals with intellectual and developmental disabilities. So there's certain things that you need to understand about state general fund, because these are used for people who do not have Medicaid or insurance. It's also used to provide jail diversion and community benefit. Let's see here. Go back here. My slides are a little bit out of order today. Sorry about that. This is a description of the 1915I waiver and the guidelines that the federal government established for the 1915I waiver. One of the things that the I waiver does say is that there needs to be a firewall between those who authorize the services and those who provide the planning and the case management to the individuals. Okay. There we go. Let's go back to this. So state general fund is used to pay for inpatient psychiatric hospitalization for people who do not have health insurance or Medicaid, outpatient services for individuals without health insurance or Medicaid. I do want to make a distinction here. There is in state law in Chapter 2 of the Mental Health Code, CMHs are allowed to create a waiting list for services. We'll talk about priority populations. I do want to say that under Medicaid rules, if you hear of a CMH creating waiting lists for services for people with Medicaid, that's a no-no. That is not supposed to be happening. General fund is used to help with Medicaid spend down or deductibles so that people can become Medicaid eligible. And I already talked about jail diversion, and to cover the remaining cost of care when Medicare reimbursement does not cover the full cost of the care. What are the prepaid inpatient health plans? This is just a real quick history. When we went to managed care in the early 2000s, we originally had 18 of these prepaid inpatient health plans, which I will define in a moment. And in 2013, 2014, we went from 18 to 10, and this just explains the process. So when we started managed care, this is where we decided to go with what I referenced earlier, behavioral health carve-out. And when we created that, meaning all the money was set aside only for community mental health, and it's still that way, as I talked a bit earlier about the 1915 and 1915C waivers, that was what comprised, that was the type of Medicaid that funded our system. If you're not familiar with the 1915C waiver, an example, if anybody on this call has a child with serious emotional disturbance, we have what's called the SED waiver. The SED waiver is only for those children and adolescents who, but for the waiver, would be in an institution, which currently we don't really have a state hospital for children right now. Hawthorne Center, the only one that was left, has been being torn down and rebuilt, and we have children at Walter Reuther Hospital in Westland, which is an adult psychiatric hospital. If you're interested in knowing more about Medicaid managed care, this tells you where you can find out more. Medicaid managed care in our state is governed by the Code of Federal Regulations at 42 CFR 438. The PIHPs are governed by these Medicaid managed care rules. And online, you can find, because it's all public information, you can find an executed copy of what we call the Master PIHP, Michigan Department of Health and Human Services Master Contract that governs the Medicaid. You can find it online. And it is, I need to fix that. It's approved by CMS, not CVS. I talked about the fact the PIHP model is a federal designation. It's a managed care entity. It exists in 20 states. when they created the first prepaid inpatient health plans, the first 18, in order to become a PHP, a CMH, or a county had to have at least 20,000 Medicaid beneficiaries or Medicaid covered lives. So again, here's just a little bit more information about the PHPs. And this is a map of the current PHP regions. They went live 10 years ago, January 1st of 2014. And we'll talk about the functions of the PIHP, because if you're not familiar with what their function is, and you might not know, it's important to know who they are and what they're supposed to be doing, because they actually have two functions, and we'll talk about that. So prepaid inpatient health plans and their role as providers of accountability and oversight. So the 7 administrative functions of a PHP are as follows: general management, financial management, information systems management, provider network management, utilization management, customer services, and quality management. Now, why am I belaboring the point? Because of the way these PHPs are configured in our state, a lot of times things like provider network management, which is something that would be important to anybody seeking services, because it's going to tell you what providers of what services are available in your area. Utilization management is who makes the decision about what services you get, or your loved one or your client gets, and how much and how often. Customer service is there to resolve issues. And quality management, and what happens in our state, because of the way that the PHP boards of directors and the PHPs are configured, a lot of times provider network management, utilization management, and customer services is actually not handled by the PHP necessarily, and is handled by the local CMH. So basically, the way that it works too, and this is important to know because you might have heard stories in the past about certain PIHPs, having to be bailed out by the state. What's unique about the PIHPs is that they do not bear all the risk for the people that they serve in their region. So the state sends, based on a formula, based on a very interesting formula in the form of what we call rate cells, which is also based on actuaries that the state of Michigan pays a lot of money to, called Milliman. They determine how much each head is worth, the capitated funds, but it's a shared risk arrangement between the state and the PIHPs. So without getting too much in the weeds, if a PIHP and the CMHs that it contracts with overspend Medicaid at a certain point, when it comes time to deal with the end of the year, cost settle, which is usually in March, the state may end up having to write a check to the PHP to make the CMHs whole, but that's a very complicated formula. Now, what happens is this. And so as it says, the PHPs get the money. They're supposed to be performing gatekeeping and authorization of services, but here's what's happened. So now we have 10 of these managed care entities, right? Now, the 3 big ones, which are Detroit-Wayne or Detroit-Wayne Integrated Health Network, Oakland County or OCHN, Oakland County Health Network, and then Macomb County or Macomb CMH. They have always been both a CMH and a prepaid inpatient health plan, believe it or not. Now, what's interesting about that is that the same board is both a PHP board and a CMH board, which is interesting when you consider that the two functions of a PHP are to write the check, the Medicaid, to the CMH. So it writes they write checks to themselves, basically. And they're also intended to monitor the way those dollars are spent. So that's the 3 that are both PHP and CMH. The other 7, which you saw on the map, which would include like the Lakeshore Regional Entity, Southwest Michigan Behavioral Health, the Northern Michigan Regional Entity, Mid-State Health Network, Region 10, those multi-county PIHPs all have the CMHs that comprise the PIHP have their own board members on the board of directors for those PIHPs. And when we reorganized in 2014, everybody reorganized under a part of the mental health code that had never been used before, called the Regional Entity Statute. So here I talk about the 10 and, you know, who is a single county PIHP and who is a multi-county. Okay. So who do they serve? And I want to be mindful of the time because I realize we're going to run out of time here. So who exactly do they serve? So if you look at the mental health code, you can easily find it online. Chapter 2 talks about the creation of the county-based public mental health system. Chapter 4 talks about the civil commitment process for adults and children. But here's just, and I'm obviously not going to read this to you, but this talks about in state law, the purpose, program, and the services of a community mental health services provider. So you've got crisis stabilization and emergency response 24/7. If somebody has Medicaid or they have no insurance and they show up at the local emergency room at the hospital, the person goes there, the hospital social worker or the doctor or somebody is going to call the CMH, who has to show up in 3 hours and do an assessment to determine whether or not the person meets criteria for inpatient treatment. And again, if a person has no insurance and they need to be inpatient, the CMH pays for the inpatient stay out of its state general fund dollars. Here's just some of the other services that CMH is to provide in accordance with state law. This does not reflect on what the requirements are when they have Medicaid. This is only in state law. And so here's more about services promoting the best interests of the individual. It's a philosophy of treatment. Here's what it says. Services shall be directed to individuals who have a serious mental illness, serious emotional disturbance, or developmental disability. But here's the priority populations. They can serve people who have other diagnoses that meet criteria under the DSM. Let's see here. And also they have to provide treatment for alcoholism and substance use disorder. But here's what I want you to look at. This is the priority population. Shall be given to the provision of individuals who have the most severe forms of mental illness, serious emotional disturbance, and developmental disability. And then, of course, those who are in an urgent or emergency situation are to be given priority. And in some cases, immediate treatment. And that's important to know. And it also is clear, no one shall be denied a service because they can't pay the bill. Under the law, we have an ability to pay. When a person, their services are being paid for with state general fund, there's an ability to pay form that they can complete where they look at all their income and expenses. But usually if people have no money, they have no ability to pay. As a matter of fact, they might be asked to apply for Medicaid. Okay. So getting in the front door, how do I ask for services? How do I find my local community mental health provider? What happens when I call them on the phone, which will be your first contact? What happens if the provider, CMH, says yes? And what happens if they say no? And if you want to know who your community mental health services provider is, here's the state of Michigan website. There's a map and it can tell you who your provider is. Okay, so you locate the provider. And what you're going to do is every CMH must have, according to the access standards in their contract, they have to have an access center. They have to have an access line that's dedicated to people calling to either find out about services or crisis, because even though we have 988 in this state, we have the MyCal, which merged with 988, the Michigan Crisis and Access Line, CMHs still have to maintain their own crisis line in their own CMH area. They still have to have that because they have to deal with crises locally. Let's see, so here's information about 988. Okay. So when you call, they're going to want to talk to you or your loved one over the phone. There's going to be an initial screening to determine whether or not your loved one's eligible for services. One thing I do want to caution you is do not minimize your loved one or your client's symptoms. If you minimize them, they're likely to say you don't meet criteria. And if you have Medicaid, they'll say, well, call your health plan. The difference between the health plan and what community mental health provides is huge. Health plans are going to provide basic mental health treatment like psychotherapy and psychiatry, whereas community mental health, again, their services are designed to help people with the most severe conditions. So they're going to provide services like case management. So you might be asked, well, gee, how many times have you or your loved one been in the hospital? What's the diagnosis? And again, if your loved one or you or your client are deemed to be not severe enough, you can be referred to another provider. After the phone call, you should be given an intake appointment for an assessment where you actually go into the CMH to have a face-to-face assessment with the clinician through the access. They use different terms, but pretty much they use the term access center. So you go in there and you go with your loved one, or your loved one goes in or your client goes in. And I have this happen. I tell people, go to the CMH. They go through the whole process and they're told, well, you don't meet criteria. And I will tell you that as an advocate, of course, I hear the worst stories. So I've had calls from people who have adult children with serious mental health conditions like schizophrenia. They've had multiple hospitalizations, homelessness, and to be honest with you, we're told you don't meet criteria for our program, which is not true. So because we're dealing with public dollars, you have your loved one, your client has what's called rights to due process, meaning if you don't like a decision made by a government funded program, you have a right to challenge that. And that applies to Medicaid dollars and it applies to state general fund dollars. There's a big difference, though. There's actually more rights to due process when you're dealing with Medicaid dollars than when you're dealing with state general fund dollars. So number one, and I'm included in this, and I tend to get into the weeds. So some of this I'm going to breeze through. It's a little bit redundant, but it has more detail. Because I took right out of the contract, the state has a contract with each CMH for its general fund dollars. And so I cut and paste from the access standards. Basically, if you or your loved one or your client go into CMH and they're told you don't meet criteria, we can't help you, they need to be told in writing about their right to a second opinion. And I find that this is a problem in this state where CMHs do not routinely tell people coming to seek services that they have a right to request a second opinion. So basically, and they can also access what's called the local dispute resolution process, but you really start with the second opinion. So it says here they're supposed to provide the second opinion in a timely manner. And actually, the second opinion is in the mental health code under Chapter 2, and also it's mentioned in recipient rights in Chapter 7. But basically, you say to them, I want someone else to assess me who was not involved with the original decision, or you can also arrange for the person to obtain one outside the network at no cost. This is something people don't know. Because clearly, if you want this to be fair and impartial in some areas of the state, you might want to go outside the network. And you also have the right to a face-to-face determination, not an assessment over the phone. They're also supposed to give you a hard copy of the screening decision so that you have it, so you know why they might have said yes or no. And here's all the things that the decision shall include. A lot of documentation. I have not seen these screening decisions this detailed, to tell you the truth. So like I said, you can ask for a second opinion. You want to put it in writing. And I tell people about this because, again, not all people are informed of the right to a second opinion. You should be told by the CMH how to request a second opinion and how the process works. And then here's the reference to the mental health code. Now, know that what happens with the second opinion is that it actually goes to the executive director or the medical director. And so the executive director is supposed to speak to an appropriately credentialed mental health professional. And basically, if the second opinion comes back, no, this person is eligible, then the CMH has to provide services to the person. So I wanted you to be aware of that. Now, this applies to whether you have Medicaid or general fund, the second opinion. But if you have Medicaid or My Child, you're able to then go through an appeal and then onto the Medicaid fair hearing process if you want. Now, again, you have to get these things in writing. I think as an advocate, one of the things that I realize a lot of people don't know because they're not told is the importance of getting those things in writing so that you have a paper trail. What I also want to mention is that if you don't get in the door, and I'll be talking about this in a moment, if you still, after the second opinion, don't get in the door, and this will apply to hospitalization too, although I will say that I'm not fond of the state's local dispute resolution process because it could be a lot quicker when you see the process. You do have a right to go to the Michigan Department of Health and Human Services and ask them to intervene. So while we're talking about denials, I also want to talk about denial of inpatient hospitalization. So if an adult is denied inpatient hospitalization, if the parent of a minor child is denied, you can ask for a second opinion. And again, the executive director is the one who's responsible for making sure that that second opinion happens, and it needs to be done with the assistance of the medical director. This is for kids, has to be done within, as it says, within 1 business day. Now, there's also an expedited process for psychiatric hospitalization denials. So the mental health code says that in the event a physician or licensed psychologist outside of CMH attests in writing that the individual meets the definition of an emergency situation as defined in the code, the CMH must assess the individual to determine if he or she meets inpatient admission certification criteria as defined in the code. If you know anything about that, that's Chapter 4, the Mental Health Code. In 401, where there's criteria that talks about who is a person requiring treatment. If services are denied, then the individual must be informed of his or her rights to the local dispute resolution process, which would typically go through, again, it's unique to each CMH. It should go through either the recipient rights office or customer service, but that decision has to be reached within 3 business days, which really, when you're in a psychiatric crisis, is a long time to be wondering, am I going to get appropriate treatment or not? In the event that the person decides to use the local dispute resolution process, the CMH must communicate in writing the outcome of that process. You have to send this request to the Michigan Department of Health and Human Services, and they have to make the decision. Which, one of the things I want to ask the state, is there a fax number or some other way to do this? Because if you have to sit down, write a letter, mail it off to the state, and wait for them to make a decision, that seems lengthy to me. So I know I'm breezing through this, and I'm looking at the fact that it's almost 7 o'clock. Kristen, do we have any questions in the chat? No? Okay. So again, you're going to get this PowerPoint with resources, because I know that this is a whole lot of stuff to take in. Now, if you do get services, what should you expect? Well, first of all, you should be given information about the services that are available. You should also be given a customer services handbook that describes the services, how they work, the network providers, and it should also explain to you your rights or your loved one or your client's rights as a recipient of services. Here's a good example. Southwest Michigan Behavioral Health has a really good sample of a handbook. The handbook's actually, there's a template that's created by the state. Now, the PHPs can augment what's in those handbooks, but there is a basic template. There's certain things that each handbook must have. So anybody getting services should be given a handbook. So you get in the door, you get the handbook, you know, you get the appointment with, let's say, the case manager who's going to be helping, you know, you or your client or your loved one get what they need from the community. And so the one thing that's also very important, and I don't spend a lot of time on this for obvious reasons, because this is a long presentation, but you should be told about about what's called the person-centered planning. And person-centered planning is a process. It's a way to create an individualized written plan of service, or you'll hear it called an individualized plan of service. But the individualized plan of service, or IPAS, is actually like a contract between you, your loved one, or your client, and the community mental health. And what goes in that plan is vital. So as you can see, a pre-plan has to be developed within 7 days of services starting, or if an individual is hospitalized for less than 7 days before discharge or release. So there has to be that plan. And one of the things I want all of you to know is that what I recommend is, for person-centered planning in our state, you can ask for an independent facilitator, and I'll talk about that in a minute. So here's what it says a person-centered plan or a treatment plan should address. It should talk about food, shelter, clothing, health care, employment, transportation. It needs to be kept current and modified when indicated. For example, if somebody is hospitalized, that would mean a change in their level of care. It should be reviewed and amended. Person-centered planning is a process. So what it means by person-centered is that the person who is the focus of the plan should be able to invite whoever he or she or they want to their meeting. So if they want their aunt, uncle, cousin, best friend, whoever they want, those individuals should be included in the person-centered planning process at their request. Also, a plan should be looked at annually. It needs to be redone annually, but I want to let you know it can be done at any time. It's not the 10 Commandments. It's not written in stone for an entire year. Matter of fact, it should be a fluid and interactive process so that if something changes, person-centered plan, the individual plan of service should be looked at. And that's where independent facilitators come in. And when I do individual case advocacy, I always ask for an independent facilitator. An independent facilitator is paid for by either the CMH or the PIHP. It depends on the region. I think the CMHs are paying for that service nowadays. And the independent facilitator is not the person who works for the provider. It's not the supports coordinator or the case manager or the therapist. It's a person external who isn't really an advocate, but makes sure that the person-centered planning process is fair and impartial. Because I can tell you as an advocate, what goes in that plan is vital. Whatever services you need, or the loved one or the person needs, they go in that plan. What will happen is it will go through a utilization management process, and whoever does that may agree or disagree about what we call the scope, amount, and duration of services. And that's why I always tell people who call me about services or service-related problems, they'll say, we're not getting this, we're not getting that, we can't get this. I say, then you need to reopen that plan, you need an independent facilitator, and you need to know very clearly what services you want and need, and you need to request that they be put in there. If they say no, well, then that starts a whole different process around rights to due process and administrative dispute resolution, what we call an appeal, Medicaid fair hearing. And they should be telling you about available independent facilitators. I'm finding that that doesn't always happen, but it should be. So again, what is it? It's a IPAS, a document or a plan developed through person-centered planning. It's like a contract. And again, things need to be clearly outlined in that plan. If you want a service, like I get calls from families or individuals who want to go to a specialty place like a Rose Hill Center in Holly, and they'll say, we really want our loved one to go there. I'll say, well, if you want that, we have to find a way to get it into the plan. If it's not in the plan, it won't be authorized, and you can't dispute it unless they flatly say, we're not putting it in there, which does happen. The other thing I want to remind you, here's section 712 of the Michigan Mental Health Code. This is, again, chapter 7. You can ask to open that plan up. If it's not completed in 30 days, that's a rights complaint. So again, it's not the 10 Commandments. Some people think it is. It can be amended, and it should be if the person's condition changes. It should be changed. What services are available in community mental health today? If you want to know all the detail, I cut and pasted in some slides because you're going to have access to the slides. I'm not going to go through all of it, but the Medicaid provider manual will tell you all the services that your loved one, depending upon their age and their condition, may be eligible for in that Medicaid provider manual. And remember, it's chapter 3. Because the Medicaid provider manual is over 2,000 pages. But if you click on it, on the left side, a table of contents will drop down and you can click on behavioral health and developmental disabilities. So remember, you can ask for information about all these topics. How do you access services and supports? Getting a second opinion, the right to pre-planning meeting and an independent facilitator, and to know what exactly is available, because a lot of people don't know. They have no idea what's actually available to them or their loved one. So that kind of concludes my slideshow. And now what I'd like to do is just if people have questions or comments or things that they've experienced, I'd like to take the remainder of this and just kind of talk about that. Kate Dahlstrom, you have your hand up?
I do. You can count on me for questions. So one of the problems that we have, and I'm sure others have as well, is that when the police may take someone to the emergency room for assessment, or they may be going there under an AOT petition or whatever, and they get assessed by the hospital team and are denied inpatient hospitalization. And so then, according to what I think you have just said, they could, the police or the family or whoever could request a second opinion under an expedited process, and that would go to the CMH CEO, or could you ask for your own psychiatrist to do an assessment? We have a lot of people being rejected for
Yeah.
inpatient care.
So first of all, I want to make sure that process only applies to people with Medicaid or people with general fund who are being served through CMH. Because if somebody has Blue Cross Blue Shield and they go to the hospital and the hospital won't authorize inpatient, none of that applies to that. So I want to make sure I say that.
Yeah.
But yes, so the way that exactly what the law says is that you do have a right to say, I want somebody else to do an assessment. You know, I want my private psychiatrist to write a letter saying that I think that the person is eligible or should be hospitalized, and I want that to go on the record that that's what I said.
And so you say that to the hospital then, or do you have to go to your CMH or what?
Well, at that point, so since CMHs are the ones that authorize all inpatient stays for anybody without insurance or Medicaid, you would be dealing directly, you should be dealing directly with the CMH. Now, I say that knowing that it should be. Sometimes there's not uniformity in our state. So sometimes I'll be taken off guard by, well, but in our part of the world, we do it this way. But for authorization of inpatient stays, for the 46 CMHs, it's a CMH that's going to make the decision, because even though we have PHPs, in most parts of the state, the CMH is the one that pays the hospital bill. And that's the other thing that I want to make sure I say. Here's what makes this more confusing. Let's say you or your loved one or your client have McLaren Medicaid health plan. If that person with the McLaren Medicaid health plan needs inpatient care and goes to some hospital, here's what's going to happen. The Medicaid health plan does not pay the inpatient psychiatric hospital bill. That's where it gets confusing for people. The CMH of where the person lives is the one that's going to be on the hook for that inpatient bill, not the Medicaid health plan, which is really confusing to people.
And if they're covered by Medicaid, that comes under a capitation rate allowance or what? Yeah.
Well, the way that the funding works is they get so much money based on the number of Medicaid covered lives in a PIHP region. It's a formula. There's rate cells. They get payments based on the number of people who have temporary to needy families. Usually that, when I was doing my thing, it was like $1 something per head. Not everybody's going to use the services. But what you need to understand is that for CMHs and PIHPs, there is no fee for service. It's all based on their capitated amount that they're going to get based on what the actuaries decide at the state.
At the beginning of the year. So if you have a lot of inpatient stays, you're not getting any extra, right?
No, you don't get extra. But I will tell you this. You get a projection, usually in the summertime, based on what Milliman projects the amount of Medicaid they think that there's going to be available. But here's the thing to remember about this. and this is where I have empathy for CMH. When times are tough and you have a lot of people on Medicaid, like we did during COVID, when they had, like, people were allowed to stay on Medicaid, Healthy Michigan, even though they might have been making too much money or whatever. CMH has had a lot of extra Medicaid because of that. When
Right.
Medicaid enrollment drops, their revenue drops. So I think it's really important to mention that. But to go back to your question, Kate, and it's in the slides, there is a process for an expedited, second opinion when there's a denial of inpatient. I think what I'm not clear on is how many people actually avail themselves of that and how many CMHs actually do it. That I don't know the answer to. I just want to get the information out there. Thank you. Allison has her hand up.
Well, I'm glad Kate asked that question, because in Traverse City, we do have a hard time getting folks, whether it's AOT or hospitalization or whatever the case may be. We get a lot of denials. I work for the sheriff's office in the corrections side. So these folks are already in my custody. And oftentimes we're trying to, their behaviors are so problematic, and they're waiting for forensics to do an eval, that we're trying to manage their needs in the best way we know how, as people who work in custody, not mental health necessarily. That being said, if they're in our custody, that's our bill. So would we be able to do that second opinion with CMH, knowing that the bill is falling on us and not CMH?
Well, we probably should have a call outside of this session to really talk about that.
That's not a bad idea.
What I would suggest is, and I can send Kate a template. I can give you a template letter where you could fill in the blanks and help people ask for a second opinion themselves. It's if you put it in writing, and then we could follow up with the recipient rights office, because the rights office should really be paying attention to this. And they might be the ones actually for you to have a conversation with. So,
well, I do know people that work in the recipient rights office, so maybe that's where I need to start.
Well, yeah, because it asks them, again, everyone does it different. It would either be the rights office or the customer service people helping with the second opinion. Some places, the customer service person is the rights office if they're a smaller CMH. But that is where I would start, Allison. And then I can also send you a template letter if that would be helpful.
Thank you very much. Kate and I work in similar groups of advocacy folks, and any way you can be helpful to us, we appreciate.
No worries. Rosalie.
How does all this CCBHC fit into this?
The certified community behavioral health clinics, which a lot of people have heard about, they are not going to provide the same level of specialty supports and services that community mental health is supposed to provide. So CCBHC is not going to be providing community living supports like any of the 1915I waiver home and community-based services that I talked about earlier will not be provided by CCBHC. CCBHC is simply, it's sort of talked about like it is integrated care, but it's not full integrated care. It's care coordination. CCBHCs are not required to have a primary care physician on site. So, I mean, they have certain requirements, but these types of services, and they're also not going to deal with inpatient psychiatric treatment. Very, very different when you look at them, when you compare them with a community mental health service provider. Is that helpful?
Not really, because CCBHC is provided by CMHs, but for mild to moderate, but what if they're actually severe and CMH is keeping them in the CCBHC part and they're still not receiving what they need?
Well, that's an issue. I mean, CCBHC, I mean, not every CMH is a CCBHC, although I think they're moving in that direction. They have to get more funding but there's other entities that are CCBHC. I think from an advocacy point of view, I can appreciate your concern, that someone could be getting services in a CCBHC when they really need CMH services. And I think that's a legitimate concern, if I'm hearing you correctly.
Right, because it's all a big mystery.
Yeah, it's a very complicated system. And I want to make sure that before we end, someone asked about what's called the WAS school lawsuit, and how that affects self-determination rates for people with the HAB waiver. And I also want to talk about a really good lawsuit, especially since we talked about person-centered planning, called CB versus Livingston County Community Mental Health. I want to make sure I talk about that. Did I answer your question, Rosalie?
Oh, yeah.
Okay.
My hand's still
Marianne, you
up.
have some people in the chat that have some questions.
Okey-doke.
Anne would like to know, can you talk about who is on staff and what services a typical kid can expect and who can access respite services? Maybe the example could be an autism diagnosis.
Okay, sure. So respite, I just want to preface it that Kristen mentioned, years ago, I worked for Michigan Protection and Advocacy, which is now known as Disability Rights Michigan. And I helped a lot of families with respite. Respite services are subject to the person-centered planning process. And what I've observed over the years, and this was over 20 some years ago, CMHs would say things like, there's a cap on respite. Families can only get 20 hours a month or something. That is not the way it's supposed to work. All services are supposed to be dictated by that person-centered plan and what's considered to be medically necessary. One of the problems that has occurred with individuals who have autism that I've seen a lot is that, let's say a child under the age of 21 is determined to be eligible for ABA, Applied Behavioral Analysis. And so they will go through the whole process of being evaluated with the ADOS, which is the tool they use. It goes up to the PHP. Anyway, they get in the door. Clearly, if a child or an adult has autism, the family's going to need respite. They're going to need community living supports. They're going to need supports coordination. If somebody says, well, if it's a child under 21, well, your child can only get ABA and nothing else, that's not true. So the difficulty is that because we have such high turnover in the public mental health system, the people that used to have a lot of the institutional knowledge aren't there anymore. And so that's why sometimes you get this misinformation about what people are eligible for. And again, I want to encourage you to go look at the Medicaid provider manual. But any service for any population group, like for someone who has autism or somebody who has a developmental disability or a child with serious emotional disturbance, that service, if it says it's for all the people served by CMH system, like community living supports, then they should be eligible for that. And there should not be arbitrary caps placed on any of those services. It should all be determined by person-centered planning, because I'll tell you what I've encountered. Adults with serious mental illness in our state, I've gone to CMHs who've tried to tell me that those folks are not eligible for community living supports or supported employment. Only adults who have developmental and intellectual disabilities are eligible for those services. And in one CMH, I said, show me where that says that in the Medicaid provider manual, because that's not what it says. But this is what happens. So I'm hoping I'm answering your question.
You did. Thank you very much. I appreciate it.
Okay, there's another question from Carolyn. She's asking, with the lawsuit ruling recently to raise hourly wages for CLS or HSW recipients, how long will that take with legislation to transpire? And then will case managers be trained on how to write those goals? Many are now also being denied goods and services too for HSW due to the wording saying it must reduce human supports, which is not possible for those with 24/7 LOS support needs.
So Carolyn, thank you for your question. For everybody, if you're not familiar, what she's talking about is, if you heard me earlier, I talked about the 1915C waiver. The habilitation supports waiver is specifically for adults with developmental, intellectual, cognitive disabilities, physical disabilities over the age of 18, who, but for that waiver, which means enhanced services, enhanced supports, but for that waiver would be in an institution which we no longer have, because the last ICFMR in our state, Mount Pleasant Center, closed down in 2009. What she's referencing is a lawsuit called WASKUL, WASKUL versus Washtenaw County Community Mental Health. And that federal lawsuit, which went on for about 5-6 years, was filed by Disability Rights Michigan, the Center for Economic Law and Justice, and Washtenaw Association for Community Advocacy. And it's a great win, because what the federal court ruled is that there has to be a minimum rate for what's called self-determination. Now, if you don't know what self-determination is, that's a whole different conversation. But in essence, self-determination means that a person gets a Medicaid budget based on the services in their plan. The dollars are handled by what's called a fiscal intermediary. And basically, the person or their family becomes an employer of their own community living support provider, their own respite provider. And what was happening is providers, like regular contract providers, were getting a lot more pay for providing CLS. But what was happening was, because of the administrative costs, because the way that community living supports is billed is it's in 15-minute increments. So it's like 15-minute sessions, okay? So you'd have a provider like a nonprofit getting $30, $40 per unit per hour of able to bill for community living support. But what they were doing with people who had self-determination arrangements, they were limiting it to a lot lower. Well, you know, one of the reasons why we have a direct care worker problem in this state is because we don't pay them enough. And if you can't pay people enough to provide care to people with the most significant disabilities, how are you going to find people to do that? You're not. So in WASKUL, the federal court said it's got to be at least $31 an hour, I believe. To answer the question about how this is, well, number one, since it's a federal court ruling, it doesn't go through the legislature. The legislature is going to have to appropriate dollars. That is the one thing they'll have to do. But since this affects the Medicaid program, this is something that the Michigan Department of Health and Human Services is going to have to write policy and rules around and then implement. So that will be the process. While I'm talking about it, I also want to talk about a similar case that I want to make sure I talk about, called CB versus Livingston County Community Mental Health. We just got word on Friday, and I helped with this case. This is important about person-centered planning and authorization of services, because for the first time ever, families, individuals can actually seek financial damages from the CMH for not providing the services. In the Livingston County case, you had a young person who's now 24 who had significant physical and developmental disabilities. The services were authorized in the plan, the community living supports, the respite, but the ongoing story from Livingston CMH was, we can't find anybody to provide the services. So when the services weren't provided, the way Medicaid looks at that is a suspension of services. Well, you can actually go through an appeals process for that. So Disability Rights took the case, they took it through the appeal, they took it through the Medicaid fair hearing process. The administrative law judge said, these services are authorized, provide them to Livingston. Livingston didn't. So what Disability Rights did is they filed what's called a mandamus action in circuit court. And what a mandamus action is when a higher court impels or compels, basically tells a lower court or a governmental entity like CMH, because they are governmental, they're county based, you have to provide these services. Well, Livingston still didn't do it. Then there were some other things that happened. Well, it ended up in the Federal Court of Appeals. And I was able to attend that oral argument. Basically, there were 3 federal judges, and one federal judge in particular really went after the Livingston CMH attorney because he kept saying, well, this is a waste of time. Why are we here? They want to provide these in good faith. And one of the judges said, don't you get the money for these services, whether you provide them or not? And of course, the answer is yes, they do get it. Anyway, the long and the short of it was a good decision, said that the plaintiff could seek damages. And on Friday, I found out from the attorney at Disability Rights Michigan, the family was awarded $100,000 in financial damages. So that's a process that's still being worked out. But if anybody on this call, or any of you know people who have services authorized in an individual plan of service and they get the story, well, we can't provide it because we can't find the people. Because I can tell you from experience, if you want to get something done, you just offer enough money and you can get it done. You give them enough money, you can do it. They need to go through the appeals process, the Medicaid fair hearing process. They go through the fair hearing process, the judge affirms it. In 72 hours, if those services don't start, then they start calculating the damages. And I wanted to make sure that I talked about that case. Of course, that process will need to be developed. But if you go on the Disability Rights Michigan DRM website, you'll see both of these cases discussed. Rosalie, did you have another question?
I don't know how to put my hand down.
Oh, okay. Mark Creekmore.
Hi, Marianne.
Hello.
Who, on what grounds, is an authorization made for inpatient services for CMH, for Medicaid and for, private insurers? What are the grounds? What are the criteria?
I think that's a really good question, Mark. I know they really rely on Chapter 401 of the Mental Health Code. They really look at, let me pull it up on my phone so that I don't, but it was changed. So here's one thing I do want to say. For years, people read 401 of the Mental Health Code to say, unless you're actively suicidal or homicidal, you can't get inpatient treatment. And so a couple people got together and changed that, because we know that there are people who might not be obviously homicidal or suicidal, but if they don't get treatment, they will be. So let me read that. So a lot of them use that section of the Mental Health Code, and I can give the citation. Okay. So if you're interested, and if you've ever had to civilly commit somebody, what they will look at is, it's in Chapter 1, it's 401. So here it is. It's 401, person requiring treatment, and it's defined. So first of all, it's in a person who has mental illness, who as a result of mental illness can reasonably be expected within the near future to intentionally or unintentionally seriously physically harm, injure himself, herself, or another person individual and who has engaged in an act or acts, this is the important part, engaged in an act or acts or made significant threats that are substantially supportive of the expectation. Now, here's the other ones, though. It's not just that one. An individual who has mental illness, result of that mental illness is unable to attend to those of his or her basic physical needs, such as food, clothing, or shelter, that must be attended to in order for the individual to avoid serious harm in the near future, and who has demonstrated that inability by failing to attend to those basic needs. And then finally, an individual who has mental illness whose judgment is so impaired by that mental illness and whose lack of understanding of the need for treatment has caused him or her to demonstrate an unwillingness to voluntarily participate in or adhere to the treatment that is necessary on the basis of competent clinical opinion to prevent a relapse or harmful deterioration of his or her condition and presents a substantial risk of significant physical or mental harm to the individual or others. So I read that aloud because that is the criteria that should be followed. Here's the problem. Not all human service types or mental health professionals or medical professionals who work in emergency rooms who do inpatient screenings actually know that the mental health code was updated in 2018, 2019 and has that language now. Because you can hear, it doesn't say, oh, well, only if they're in the, talking about hurting themselves or others. It looks at a whole lot of other criteria.
Mhm. So it has to occur through a emergency department.
Typically, Mark, it does. What happens is if you have Medicaid or no insurance, you go to the emergency room and then they call the CMH access center people, who's on call, to do the assessment and make the determination. And I get calls where the hospitals don't always agree with CMH. There are times that people who should be hospitalized are not hospitalized, and I have to say that I don't always understand the rationale for the decision-making process.
Thank you.
You're welcome. Carolyn.
Hi, Marianne. I just wanted to tell folks that I put the links for both of those cases you discussed in the chat because I had a hard time finding it on the Disability Rights Michigan website. So I put them in the chat if people need those.
Oh, well, thank you. Kristen, any other questions in the chat?
I don't see any. At this time, if you have a question you'd like to ask, go ahead and unmute yourself and ask your question to Marianne.
I was wondering what expertise CMH has on staff, like psychologists, psychiatrists, social workers, therapists. Can you just speak for 30 seconds on that, if you know?
Yeah, I think what's happened, and here's what I can compare it to. Over the years, I think what happened was people that had worked in the system for a long time left. I'll give you a good example. Back in the 90s, I was a case manager working with adults with serious mental illness for Oakland County CMH, and I was a lot younger, and I was fortunate to have worked with a lot of social workers, psychiatrists, other mental health professionals who'd been in the system for over 20 years since it was founded. And so I had a lot of really good supervisors and, that I could go to, people with a lot of experience. There's so much turnover in the system right now because what happens is a lot of people just getting their master's degrees or their bachelor's degrees end up working in the system. And the problem with that is that there's not a lot of good preparation in colleges and universities for knowing how to effectively work with individuals with the most severe mental health conditions in our state. And so if those young folks or people who are, coming out of school don't have access to seasoned professionals, in my opinion, it makes it very difficult. So a lot of these folks don't necessarily have a lot of experience. And colleges and universities don't typically provide a lot of education about the types of conditions that CMH, types of conditions that CMH staff would typically see, like schizophrenia, like bipolar 1, like children with serious emotional disturbance with more significant behavioral health conditions. They're not really always adequately prepared for that. And as a clinical social worker with a master's degree, I can tell you that I went through a very good school, but when you get out of school, it's on you, in my opinion, to get a lot more education about these conditions, because you can't really rely on your employer to provide that to you. So I think we're seeing a lot of turnover, and that's because people come in, they get their clinical hours done, and then they move on.
It's too bad.
It is.
Too bad there's not training in the budget or something like that.
There is for CMH, there's certain mandatory CMH trainings, but they're not focused on necessarily clinical training. I mean, there's some things people get trained in, like some people get trained in dialectical behavioral therapy or motivational interviewing, or they get trained in administering what's called the locus, which is used to determine the level of care for adults with mental illness coming into the system. Or now Michigan is moving away from the CAFIS and the PECFIS for kids and moving toward what's called the CANS. But when it comes to actual understanding about these conditions, I think people kind of learn it as they do it. Rosalie.
What do you think about all this funding going to the schools for mental health treatment? Do you think that's going to be effective, or is it going to be CMH passing the buck back to the school?
Well, they're going to be, I mean, there's a bill out there right now that, for example, there's a counselor's bill that says that districts must have one counselor for every 250 students. And we were calculating that at a meeting within MHAM. That means that there were like school districts across the state would have to add across the state like 80 counselors, which, we have a mental health professional shortage. I think the issue is going to come down to this. We don't necessarily provide mental health treatment in the schools, although there is a way to do that. I think it's more about responding to what happened in Oxford and to a larger degree, and to some degree, Michigan State, the shootings. But at the end of the day, here's what I'll say. We can identify people all day long who need treatment, but we have to have places to refer them to. And so while I agree we do need more social workers in the schools, we need more school counselors and psychologists and all that, we also need outpatient providers to provide services to these kiddos that are going to need the help, because the schools are not going to be, they're not equipped right now to do all of that. So I hope I answered your question. So any other questions, Kristen?
Let's see, we got Carolyn said most schools also no longer have school psychologists on staff. She was just giving a comment.
Well, that concludes my presentation. I'm realizing it's 7:35. I hope this was helpful to you. Our goal is to provide more education to those of you that either are a person seeking services, or if you have loved ones or clients, because, the advocacy piece is vital. And a lot of times people that I encounter, they really do not know what they don't know. And so they'll say to me, well, I didn't know I could get that, or nobody told me I could get that, So I hope this was helpful. Obviously, we could be here for days, but go on our website, Mental Health Association in Michigan, and our contact information is there. It also is in the slides that Kristen's going to send out. And You're welcome to everybody. It was a pleasure talking with all of you. I know it was a ton of info, but please reach out if you have any other questions or if you have any other topics that you would like us to try to cover. Thanks for coming today, and I hope you all have a wonderful evening. Enjoy this really strange and bizarre warm weather.